Hi, this is the Voiceover PowerPoint for chapters 53, 54, and 55. They are the same chapters regardless of whether or not you are in the 13th edition or 14th edition. The page numbers, however, will be different, but the chapter numbers are the same. For chapter 53, we are discussing assessment of kidney and urinary function. Towards the beginning of the chapter, there is a section on anatomy and physiology, and that review is a self-study. I do, however, suggest that you review the renal function animation on page 1510 of the 13th edition and 1550 on the 14th edition. It is very important to understand the role or the functions of the kidney. This is listed in detail on page 1508 of the 13th edition and 1549 of the 14th edition, chart 53-1, regardless of the edition of the textbook you're in. Within this chapter, it is also highly suggested to review age-related changes. The aged or elderly have a decreased sensation of thirst, decreased filtration rate, and decreased ability to empty because of contractility issues. And if they can't empty, this does lead to stasis, and therefore stasis of urine leads to further problems. Moving on to assessment of the urinary tract. Normal voiding is 1 to 2 liters within 24 hours, which averages out to about 30 milliliters an hour or more. If once we assess and realize there are not at least 30 milliliters an hour, then we definitely know there's some type of problem. Several questions we need to ask somebody with regards to the urinary tract, especially if they're admitted, with renal or urinary issues. History of UTIs, family history of UTIs, any changes in voiding pattern or changes in the urine. Regarding the physical exam, understanding that kidneys are not usually palpable, but tenderness over the costovertebral section or the flank area may indicate that there is some type of renal dysfunction or problem. Another indication would be ascites, fluid-filled abdomen. If a patient does have ascites, we want to measure I do apologize for that interruption. With regards to ascites, we do need to measure the patient's abdominal girth on admission, and then measure at every shift to see if there are any changes with regards to the abdominal girth. We need to assess for edema and document location and whether or not it's pitting. So location, is it in the bilateral lower extremities? Is it generalized edema throughout the whole body? So be very specific with that. To check residual urine, they could always do a straight cath after voiding to see how much urine is remaining in the bladder. Within the office, they can do a variety of tests where they actually measure the pressure while a patient is urinating. Then they provide fluid to see how much is the patient's able to retain, and then once they empty, is there any residual left? And then the most non-invasive way to check is by use of a bladder scanner. We would also assess for any urinary incontinence, and remembering again with the patient's voiding and voiding patterns, we do need to make sure they are urinating at least 30 milliliters an hour. BPH or prostatitis can affect urinary elimination. At what age should the digital exam begin? And that's at age 40 in men and older. And the PSA levels show if there may be any issues with the prostate. Regarding the physical exam, Understanding that kidneys are not usually palpable, but tenderness over the costovertebral section or the flank area may indicate that there is some type of renal dysfunction or problem. Another indication would be ascites, fluid-filled abdomen. If a patient does have ascites, we want to measure I do apologize for that interruption. With regards to ascites, we do need to measure the patient's abdominal girth on admission and then measure it every shift to see if there are any changes with regards to the abdominal girth. We need to assess for edema and document location and whether or not it's pitting. So location, is it in the bilateral lower extremities? Is it generalized edema throughout the whole body? So be very specific with that. To check residual urine, they could always do a straight cath after voiding to see how much urine is remaining in the bladder. Within the office, they can do a variety of tests where they actually measure the pressure while a patient is urinating. Then they provide fluid to see how much is the patient's able to retain, and then once they empty, is there any residual left? And then the most non-invasive way to check is by use of a bladder scanner. We would also assess for any urinary incontinence and remembering again with the patient's voiding and voiding patterns, we do need to make sure they are urinating at least 30 milliliters an hour. BPH or prostatitis can affect urinary elimination. At what age should the digital exam begin? And that's at age 40 in men and older. And the PSA levels show if there may be any issues with the prostate. Discussing problems with urination or urinary function, there's a table 53.3. It is called Table 53.3 regardless of the 13th or 14th edition. In the 13th edition, it's on page 1516. In the 14th edition, it's on page 1556. And I would review those. Dysuria is plainly difficulty with urination. Frequency would be considered more than 3 times in an hour. Urgency, gotta go. Oliguria is another one. Oliguria simply means small amount of urine. Anuria is pretty much A, meaning without anuria, and that's less than 50 milliliters in a 24-hour period. Hesitancy regards to problems getting started, and incontinency and earlier we mentioned retention. Those are both going to be covered extensively in Chapter 55. There's diagnostic testing for urinary and renal function. Urinalysis can look at a variety of things as listed here on the PowerPoint. In regards to odor, a slight aroma or slight odor is normal. We do expect clear and not cloudy urine. We expect no sediment, no blood. It should be yellow in color and not dark. Should be a fairly pale yellow. On table 53.4, page 1520 of edition 13 and page 1560 in edition 14 discusses urine color and the causes of any abnormalities in the urine color. Also important to know the normal specific gravity value and normal pH value of urine. We can test the urine culture and sensitivity, and that's going to tell us what little critters or what organisms are running around and whether or not they're sensitive to particular antibiotics. so that the physician can assess if they're on the right antibiotic. Usually, if they do have a problem, especially with urine infection or UTI, they'll order a broad spectrum antibiotic until they get that CNS back, and then they may or may not make changes to that. There are several serum blood tests they can do. They can check the BUN and creatinine. A variety of different serum tests they could do. The jug here on your PowerPoint is called a 24-hour urine jug, and one of the physicians may order what we call a 24-hour urine. It can show progression of renal disease. They can do a variety of different tests. So depending on what they order to test for within the 24-hour urine, the lab will add additives to the jug and then have you come retrieve it or send it to the unit, depending on what they're testing for. When collecting a 24-hour urine, you have them discard the first void and then start collecting. So they'll need to urinate, you dispose of that, and that starts the 24-hour period, because we do want to show the 24-hour period of your renal function, which is kidneys making urine, and that's why we discard that first void. This 24-hour urine needs to be kept on ice, so that container will actually sit in a basin of ice. If they have a Foley catheter, the bag will also be kept on ice. They do have bags that you can wrap around it to keep it cool, and or they will also set it in a basin of ice. Every drop has to be collected for that 24-hour period. So even if you went into the room, measured the urinary output in the Pilgrim's hat, started to tip it over, dropped a few drops, and then caught yourself, that 24-hour urine would need to start from square one. So very important that you have signage available so that people do not accidentally discard any amount of that urine created in 24 hours. Imaging tests can also be done to assess renal or urinary function. When doing an ultrasound, we do need to encourage the patient to drink fluid prior to the exam. Drink plenty of water, because we do need a full bladder. A bladder scan can check the amount of urine in the bladder, which we've discussed. And again, that is a good detection of any residual. So maybe after they void, check the bladder scan and see if there's any urine left in the bladder. We've discussed CAT scans before. I just want to remind you of a couple of things. If they're getting contrast, we do want to check their BUN and creatinine first. That's assessing renal or kidney function to make sure that they can rid their body of the contrast, so it'll be filtered out without doing any damage to the kidneys. They do need to have the glucophage stopped, so prior to a CAT scan with contrast, patients should not take glucophage up to 3 days prior. Another thing they might do, especially if the renal function is kind of iffy, BUN and creatinine might be a little high, to assist with filtration of the contrast, they may order pre-procedural Mucomist or acetylcysteine, which is a medication that is normally given, and you'll learn this in pharmacology. It's a respiratory medication, an inhalant, but they can take it orally, mixed usually with cola or some kind of dark beverage. But they'll mix it with cola, have them drink it before the procedure, and that will help filter that contrast through the kidneys. And they do encourage pre-procedural hydration before any CAT scan with contrast. KUB is an X-ray. It visualizes the kidneys, ureter, and bladder. Like it says there, measures size, shape, and position, and it can detect any abnormalities, cysts, tumors, any stones, any problems as far as structural problems. You can briefly self-study the remaining imaging tests that are available in your text. They can also do an endoscopic procedure to directly examine the bladder, and that's called a cystoscopy or a cystoscopy. I prefer cystoscopy. And again, they can directly visualize the bladder, and they can also do a biopsy while they're in there. And you'll learn as we enter into cellular regulation towards the end of the semester that biopsy is the only definitive test for diagnosing cancer. That leads us also to a kidney biopsy. This helps to determine the type and stage of a renal pathology or renal cancer. They can do a skin puncture to obtain that biopsy, or they can do an incision over the kidney and obtain a biopsy in that manner. You will need that kidney biopsy information, just basically understanding that it diagnoses cancer and determines stage and type of cancer. And you'll need more of that information when you get to MedSurg 3, and that is where they talk about renal cancer. We need to do what we can while they're a patient, especially in the acute care setting or long-term care setting, to support normal voiding habits. So when do they normally void? When would they normally, we can provide our assistance at those times? How far is it for them to the bathroom normally? Do they need a bedside commode? Is their mobility affected? Put the call light in reach. Provide privacy. Positioning is really important, especially if sometimes males have troubles urinating into a urinal if they can't stand. Females may have trouble urinating into a bedpan with regards to how they're positioned in the bed. And always encourage the patient to, or you, if the patient is unable, but good perineal hygiene. This chapter has a discussion on fluid and electrolyte imbalances. Fluid and electrolyte imbalances are summarized on table 54-1, and that is page 1528 in the 13th edition and 1568 in the 14th edition. And we will also be discussing fluid and electrolytes in the following lecture, so you'll have more information provided to you at that time on fluid and electrolyte imbalances. With regards to gerontological considerations, the aged or elderly have less of an ability to respond to fluid and electrolyte changes, and when they have a loss of fluid or a deficit, this can lead to several serious issues with regards to dehydration and among others, and those are discussed later. They do have non-specific signs and symptoms also, which makes it very difficult to diagnose. Polycystic kidney disease. It is an inherited disorder. It definitely can result in renal failure. Very important to know these items. And it is characterized by a formation of kidney cysts. And this does happen to the bilateral kidneys. And once the cysts enlarge, they do rupture. And then this causes scarring on the kidneys, which results in damage to the kidneys. Manifestations of polycystic kidney disease include a dull heaviness in the flank area, hematuria, or what we call blood in the urine, and eventually they show signs of renal failure. They can diagnose this by H&P, which is history and physical. That's something that the physician provides or dictates. Ultrasound. They can also diagnose it using a KUB or kidney, ureter, bladder. X-ray. They can do a CAT scan. They can monitor and do urine for a 24-hour creatinine clearance. And there's also genetic testing available. There is absolutely no cure for polycystic disease. While there is no cure for polycystic disease, there is management, nursing and medical management, things we can do to help manage the disease. They'll need to have medications on board to control problems with high blood pressure or hypertension. They'll need to have pain medications on board because this is a painful disease. They are susceptible to infections, so they'll have antibiotics should an infection arise. Once the kidneys become damaged and renal failure sets in, they can place the patient on dialysis to replace that function. And dialysis is covered in MedSurg 3, so we do not get into dialysis in this class. And another option is a possible kidney transplantation, and that also is covered in MedSurg 3 and is not discussed in MedSurg 1. The first discussion is on urinary tract infections. A UTI or urinary tract infection refers to bacteria invading the urinary tract. Some predisposing factors are urinary stasis, contamination by, especially with females, wiping the wrong direction. They should be wiping front to back and not back to front. Or it could be instrumental contamination, which would be like the insertion of a Foley catheter. Obstruction can be a factor in urinary tract infections, reflux of urine, and a history of frequent urinary tract infections. Assessment includes vital signs, especially pain or temperature, assessment of pain, assessment of level of consciousness, urine color, amount, odor, clarity, and frequency. They can diagnose a UTI or urinary tract infection by obtaining a UA-CNS or culture and sensitivity, and that culture and sensitivity needs to be collected by clean catch method, which you guys have or will have discussed in the lab, or by urinary catheterization. And you notice I did say with that assessment of LOC or level of consciousness, and we'll be discussing that shortly. Lower urinary tract infections such as urethritis, cystitis, and prostatitis. Urethritis is inflammation of the urethra, cystitis is of the bladder, and prostatitis is inflamed prostate. The most common cause of urinary tract infections is E. coli. Signs and symptoms include urgency, nocturia, incontinence, pelvic pain, burning on urination, frequency, hematuria. Now, the gerontologic or aged population, they tend not to have signs and symptoms like that. Some common signs and symptoms would be a low-grade fever, a new issue of incontinence if they aren't normally incontinent, fatigue, and definitely confusion. I remember managing a long-term care facility, and there was this sweetest lady ever in a wheelchair, but she could wheel herself around, and sweet as pie. But when she would get violent, and by violent I mean she would normally head to the front door and start trying to karate chop it and kick it in, and she would definitely change her use of language to some profanity, and that is the first thing we would check. We had kind of a standing PRN UA-CNS order, and sure enough she would have a urinary tract infection. We'd get management on board and start treating it, and then back to sweet self. There are some factors we may want to consider with the gerontologic considerations, and the fact that maybe they have infected wounds or pressure ulcers that could contribute to the UATI, just cognitive deficits, not urinating when they're supposed to, not drinking enough fluids. They could be immunocompromised. So there's a variety of gerontological considerations with this. With regards to management and prevention, we need to think about hygiene. Definitely for the female, the wiping method or wiping front to back and not back to front. We need to encourage all to intake at least 3 liters of fluids a day. And we need to try to monitor for symptoms for early identification to detect the symptoms early so we can prevent it from becoming a very fierce or angry urinary tract infection. Pharmacological therapies, so they can order acute therapy, which would be like an antibiotic for 3 days. Sometimes if people have recurring infections, they can do more of a long-term therapy, and they might treat it like every night at bedtime for months as a preventative measure. Some of the medications we think about when we're thinking about treatment of urinary tract infections, Bactrim or sulfa, or Cipro. Those are very broad spectrum antibiotics, and they are especially good for treating UTIs caused by E. coli. There's also a drug called pyridium, which is a urinary analgesic. It helps relieve pain and burning upon urination, used in patients with cystitis. And we need to be aware that it does turn the urine a bright reddish orange in color. So would definitely want to note that change, and that it would be nothing to be alarmed about because it would be from the patient taking the pyridium. Lower urinary tract infections such as urethritis, cystitis, and prostatitis. Urethritis is inflammation of the urethra, cystitis is of the bladder, and prostatitis is inflamed prostate. The most common cause of urinary tract infections is E. coli. Signs and symptoms include urgency, nocturia, incontinence, pelvic pain, burning on urination, frequency, hematuria. Now, the gerontologic or aged population, they tend not to have signs and symptoms like that. Some common signs and symptoms would be a low-grade fever, a new issue of incontinence if they aren't normally incontinent, fatigue, and definitely confusion. I remember managing a long-term care facility, and there was this sweetest lady ever in a wheelchair, but she could wheel herself around, and sweet as pie. But when she would get violent, and by violent I mean she would normally head to the front door and start trying to karate chop it and kick it in, and she would definitely change her use of language to some profanity, and that is the first thing we would check. We had kind of a standing PRN UACNS order, and sure enough she would have a urinary tract infection. We'd get management on board and start treating it, and then back to sweet self. There are some factors we may want to consider with the gerontologic considerations, and the fact that maybe they have infected wounds or pressure ulcers that could contribute to the UATI, just cognitive deficits, not urinating when they're supposed to, not drinking enough fluids. They could be immunocompromised. So there's a variety of gerontological considerations with this. With regards to management and prevention, we need to think about hygiene. Definitely for the female, the wiping method or wiping front to back and not back to front. We need to encourage all to intake at least 3 liters of fluids a day. And we need to try to monitor for symptoms for early identification to detect the symptoms early so we can prevent it from becoming a very fierce or angry urinary tract infection. Pharmacological therapies, so they can order acute therapy, which would be like an antibiotic for 3 days. Sometimes if people have recurring infections, they can do more of a long-term therapy, and they might treat it like every night at bedtime for months, as a preventative measure. Some of the medications we think about when we're thinking about treatment of urinary tract infections, Bactrim or Sulfa, or Cipro. Those are very broad spectrum antibiotics, and they are especially good for treating UTIs caused by E. coli. There's also a drug called pyridium, which is a urinary analgesic. It helps relieve pain and burning upon urination, used in patients with cystitis. And we need to be aware that it does turn the urine a bright reddish orange in color. So would definitely want to note that change, and that it would be nothing to be alarmed about because it would be from the patient taking the pyridium. Upper urinary tract infection symptoms are just a bit different. These patients experience high fever and chills, general malaise or weakness, pain in the flank area, and pyuria, burning on urination, and usually detect pus in the urine. And so it's those signs and symptoms for upper urinary tract infection, plus all the signs and symptoms discussed for the lower UTI. Diagnosis would include a UAC&S, a BUN and creatinine, because we're definitely wanting to assess renal function with it being an upper urinary tract infection, and a CBC. And that's to assess those white blood cells for infection to see if that white blood cell count is elevated. As far as management, at least a 2-week course therapy of or antibiotic therapy for 2 weeks. We need to try to encourage them to void every 2 to 3 hours. We need to encourage fluids, 3 to 4 liters daily, and that'll help prevent any urinary stasis or the urine from just kind of hanging out. We'll monitor their vital signs at least every 4 hours, and follow up with urine cultures 2 weeks after the completion of the antibiotics. And also, like any antibiotics, we need to encourage them to finish the entire course of therapy. There are voiding dysfunctions discussed in this chapter, and there are different types of voiding dysfunction. Stress, incontinence is it could be caused from something as simple as a cough. Oftentimes, if patients can Kegel, do Kegeling exercises to strengthen the muscles down there, we would avoid such things as stress incontinence. Urge incontinence means when they gotta go, they gotta go. So no indication early on. It's just this all of a sudden urge to go. Functional incontinence refers to maybe some kind of like they can't ambulate, so difficulty getting there. Alzheimer's could be considered a functional problem. Don't worry about the iatrogenic, and on the mix, that just means it could be a combination of, like, say, stress and urge incontinence. As we continue our discussion on urinary continence, some things to remember is definitely didn't monitor intake and output. We need to encourage them to keep avoiding diary. So when were they incontinent? When do they have hesitancy, urgency? And it's very important that they keep this voiding diary. It's usually 3 or 4 different days, and they will discuss whether or not they had the urge to urinate, when they urinated, did they feel like they were done urinating, approximate amount they thought they urinated, or they'll go ahead and measure it. But very important to try to determine what types of problems or what the cause of the problems would be. Checking post-void residual, which they urinate, and then we could check the bladder scan. Or again, that urodynamic testing They're able to check post-void residual that way, as well as lots of other testing or results they can get from that urodynamic testing. UACNS, ultrasound, cystoscopies assist in diagnosis of the urinary incontinence issues. And we need to also remember that incontinence is not a part of the normal aging process. Alteration and elimination, so they do have decreased muscle tone, but this incontinence is not necessarily part of the normal aging process, and so we don't want to accept that as a age-related change. We need to think about what could be done to fix the or assist with fixing the problems that are causing the incontinence. With regards to incontinence and management, we can teach the patient Kegling exercises, which are pelvic floor muscle exercises that are encouraged that they do them at least 4 to 5 times a day. This helps with urge and stress incontinence. Training, so we could put a patient on a training schedule if they're incontinent. And we know this from the diary. If they're incontinent like every 2.5 hours or every 3 hours, then we would take them or encourage them to void at least every 2 hours. Again, fluid management, encouraging fluids and monitoring intake and output. Anticholinergic drugs are used for overactive bladder, so that it would limit the contraction of the bladder. And antispasmodic drugs suppress any muscle spasms that might be causing incontinence. I would spend a very brief time reading about the surgical management as far as suspension or the sling, suspending the bladder up to prevent any incontinence. They do have periurethral bulking, where they inject collagen into the urethra. It's a temporary fix for stress incontinence. But just, a brief reading on that. Urinary retention. Urinary retention is the inability to completely empty the bladder, and there could be several causes. This could be a post-op issue. Sometimes post-operatively people experience urinary retention, which is eventually resolved. Neurological disorders could cause urinary retention. Infection could be a cause. And then there are medications that can cause some retention, especially Provenal or albuterol inhalers, those nebulizers. So use of those can cause urinary retention. Signs and symptoms could be a complaint of fullness, voiding in frequent small amounts, sensation of the inability to incomplete emptying, like inability to empty the bladder. Management goals: prevention of overdistension, which we could insert a urinary cath intermittently, a straight cath to prevent overdistension. Trying to promote normal voiding patterns, and definitely providing privacy. Once a patient voids, it is normal for the bladder to have 50 to 100 milliliters of urine left in the bladder. As far as nursing management, we need to promote urination. There's little different tricks we can use. Bathroom versus bedpan, or commode versus bedpan could help. Different things can trigger somebody to urinate. Make sure they're not cold and they're nice and warm. Sometimes running water. And believe it or not, sometimes a trick I learned would be to take a cup of water with a straw in it and have them blow bubbles. And it does help them to relax. And the sound of the bubbling helps them to urinate. Warm compresses, hot teas, and again, different positioning. Some management of urinary retention. I mentioned earlier intermittent or straight cathing. where it's just temporarily draining the urine. Indwelling, which means anchoring an actual urinary catheter, or what we call a Foley catheter. And then there's also the option of a suprapubic catheter. Suprapubic catheters do have less risk for infection, but understand that the urine would not be clear, it would be cloudy. Main factor with regards to urinary catheterization is the prevention of infection. You guys will hear the term in clinical CAUTI, or catheter-associated urinary tract infection. So meaning when a patient comes in, they don't have a urinary tract infection, and then once we start a catheter, that would cause the urinary tract infection, and those are not covered by insurance. So if a patient comes in without a UTI and develops one, any treatment with regards to that UTI, any diagnostic testing or medications would not be covered. Minimizing trauma during catheterization. If they have had a catheter for a while, retraining the bladder. Some different things we can do to retrain a patient's voiding. No fluids after 10 p.m. Have them void at specific times. After voiding, check the residual, whether it's by use of the bladder scan or the intermittent catheter. Watch for signs of a full bladder. Anxiety could be a sign that they're retaining these fluids, and we're trying to retrain the bladder to go. Another sign could be cold hands and cold feet. Increased time between catheterizations gradually, and again, normal residual could be up to 100 milliliters, so that would be our goal, that they would not have more than 100 milliliters residual. Next is our discussion on stones, or renal calculi, or kidney stones. The term urolithiasis refers to bladder or stones in the urinary system, or nephrolithiasis meaning specifically kidney stones. These are formed when urinary salts become concentrated and settle, developing stones in the urinary tract. Urethral obstruction. Urethral calculi can also be formed. And there's a variety of items that constitute or create these urethral calculi. Renal calculi, there are some predisposing factors such as immobility, dehydration. Some meds can contribute to renal calculi, such as vitamin D, antacids, and certain laxatives. Manifestations of renal calculi include flank pain and tenderness, very severe pain right at the location of the stone, chills, fever, renal colic. It's a type of pain from the kidney stones. Depending on the obstruction, it could also be accompanied by swelling or infection. Diagnostic testing to identify renal calculi would be the kidney ureter bladder x-ray or the intravenous pyelogram. When talking about management of the renal calculi for pain, we can use the physician will probably order opioids or NSAIDs, warm water baths, moist heat. Definitely have them increase their fluid intake. Nutritional therapy, which we'll discuss here in just a moment. And there are some interventional procedures such as lithotripsy or shock waves that break up the stone into tiny particles that they are able to then pass. So we can encourage increase of oral fluids, or we can increase IV fluids, but what we want to do is increase the flushing out of the stones. If they're nausea and vomiting, we need to consider getting some nausea medications on board to prevent that. If they're able to drink, we need to encourage 8 to 10 8-ounce glasses of water a day. Some of the nutritional therapy, if they're calcium stones, we do need to try to restrict the protein and restrict the sodium and limit that sodium to 3 to 4 grams daily, and restrict that protein to 60 grams a day. We need to avoid oxalating foods. For example, spinach, rhubarb, tea, peanuts. The reason we also restrict the protein is that protein increases calcium excretion, which then leads to the calcium stones. If they're uric acid stones, the patient needs to be on a low purine diet. Some examples of purine or foods with purines would be mushrooms, asparagus, shellfish, and anchovies.